We need care that heals the body, not a system causing pain. Iron, B12, folate, feed the blood, build it back, my body's fighting daily. I should get some credit for that, but I walk in the 7-1. 3 days later, I'm at 6, too many micro drugs could fix it. Why we still playing these tricks? My blunts, your blood counts, our blood counts. Every drop of life is sacred, why they treat it like it don't count? Blood counts, your blood counts, our blood counts. Every drop of life is sacred, why they treat it like it don't count? Blood banks empty since COVID, can't keep living on transfusions. Bloodless medicine is safer, so why the same old solutions? My blood counts, your blood counts, our blood counts. We deserve care that heals, not just takes more out. Blood transfusion still the standard, though the science never proved better outcomes, better healing, or the quality we lose. But bloodless medicine is working, faster healing, lower risk. Respect the blood, protect the patient, that's the future we can't miss. We treat our blood with honor, build it strong from cell to cell. Give it oxygen and nutrients and it'll do its job well. But they draw more than we need and waste 90%. Tell me how that's good medicine when recovery's the intent. My counts, your blood counts, our blood counts. Every drop of blood is precious, why they acting like it don't blow? Blood counts, your blood counts, our blood counts. Every drop of blood is precious, why they acting like it don't count? We need science, we need choices, we need care that's evidence-based. Protect the blood inside our bodies, not replace what can be saved. My blood counts, your blood counts, our blood counts. We gotta do better, so we can feel better now. We're raising awareness for the billions who are fighting low hemoglobin, low energy, low vision, who smile through fatigue, who faint and get dizzy. But it's real, it's risky, this ain't routine, this ain't just busy. Treat our blood with respect, let the body restore. Test smarter, draw smaller, stop draining us more. We demand better outcomes, better care, better plans. Blood rebuilds naturally, just give it a chance. My blood counts, your blood counts, our blood counts. Say it louder for the ones who still go unheard and tossed out. One hit counts, our blood counts. Say it louder for the ones who still go unheard and tossed out. We want healing, not depletion. Innovation, not tradition. Bloodless medicine is safer, and it's building better systems. My blood counts, your blood counts, our blood counts. Every drop is love. Let's protect it now. Every drop matters. Every life matters. We can do better, so we can feel better. My blood counts. 한 방울도 소중해. Every heartbeat matters. 피가 생명이라면 왜 지키지 않는 걸까? This one's for the billions. 사람들은 말해 그냥 흔한 일이야. 하지만 여성과 아이들은 가장 깊이 아파. 피는 살아있는 기관, 내 안에서 숨쉬어. 우리는 치유가 필요해. 더 아프게 하는 시스템 말고 설분비로 옆산 피를 키워 다시 채워. 내 몸에 일싸워. 이 정도면 인정받아도 돼. 서울로 들어왔는데 며칠 만에 색수로 떨어져. 필요 없는 체혈이 왜 아직도 반복돼. 내 피는 중요해, 내 피도 중요해. 우리 피는 중요해. 한 방울 한 방울이 생명인데 왜 아무렇지 않게 대해. 내 피는 중요해, 우리 피는 중요해. Bloodless medicine is safer, while we still lose it more. हर बूंद मायने रखती है, हर धड़कन मायने रखती है.
All right, good morning. Sarah.
Ready to go?
Suppose so.
Okay. Greetings and a warm welcome to the final day of Bloodless Medicine and Surgery Week. I'm Sarah Wolbolt. I am the RN program manager for patient blood management at the University of Utah Hospital. Today's May 16th, World Bloodless Surgery Day. And so I'm so honored to have as my co-host this morning, Andre Burgoyne. And because he carries out every day in his work the vision of Dr. Denton Cooley, who we know performed the very first open heart surgery in bloodless medicine on May 16th, 1962. And so Andre is the Bloodless Medicine and Surgery Program Consultant at the University of Chicago in Medicine. And so I will now hand this over to Andre, my co-host.
Yeah, this has been an exciting week. So much we've learned. This week has really showcased what is happening in the realm of bloodless medicine and surgery. So we've heard a number of top-tier presentations, much peer learning as well. But we're so happy also for such a diverse international audience who really has an interest when it comes to bloodless medicine and surgery. And so today we are going to round out this week's presentations. Today is going to be the highlight for our week. We're going to have two exciting and informative talks, including the World Bible Surgery Day lecture. Now, before we begin, we just have a few housekeeping thoughts we wanted to bring to your attention. Number one, all questions should be placed in the Q&A. And also, too, just so that we can all focus, let's minimize chats during the talk so as not to distract from the attendees or even the speaker, as he's really trying or she's really trying to highlight key elements of bloodless medicine, surgery, and care. As you know, the program is live streamed on BMSS YouTube channel. And in case you have difficulty logging in onto Zoom, please see the YouTube link in the chat or simply just type in the search engine on YouTube, Bloodless Medicine and Surgery Society. And with that, you'll be able to log in and join us here and listen to these fine presentations. Two exciting, informative talks you're going to hear in just a moment. So at this time, we'll turn it back over to you, Sarah.
Hey, well, let's get started with our first keynote speaker, Dr. Mark Friedman. He's going to be presenting on thrombocytopenia, causes and management without transfusion. So Dr. Mark Friedman is an associate professor of pathology and the director of transfusion and therapeutic apheresis services at NYU Langone Health System, Grossland, Long Island School of Medicine in the United States. He has over 25 years of experience in the field of blood banking, transfusion medicine, and is board certified in the American Board of Pathology. Dr. Friedman holds membership in organizations including SABM, AABB, the Blood Banks Association of New York State, and the Bloodless Medicine and Surgery Society, and has extensively published in topics covering patient blood management, including his contributions to the PBM column for the AABB website. His research interests include insights into approach blood utilization and PBM education. So he's highly qualified, and we are looking forward to his discussion now. Dr. Mark Friedman.
All right, thank you for that kind introduction and for BMSS for inviting me here to speak on this Saturday, and of course for all the attendees who are coming out on this weekend day to hear me hear my words of wisdom, I guess. I'm going to share my screen here. Okay. All right, so hopefully now you can see my slides, right? You can? Okay, good. All right, so I was asked to talk on this challenging topic of managing thrombocytopenia without platelet transfusion. I have no disclosures for this presentation, and the presentation objectives are to discuss the importance of platelets in hemostasis, list the causes of thrombocytopenia, and then sort of go through some alternative management strategies for patients with thrombocytopenia. So I'll preface this by saying, you know, in listening to earlier talks during this interesting meeting, we heard examples of personal cases that were being managed, I really don't have any personal cases to add, this morning. Really just talking about some of the guidelines and, alternative strategies. Though we did hear some interesting cases yesterday, in one particular case, a patient apparently with ITP, with a very low platelet count, who was managed without transfusion. So that said, I believe that if you're going to avoid something, you really have to know what that thing is and what it does. So in platelets, these are cellular elements in the blood that are derived from megakaryocytes, and we know that they act in primary hemostasis. And you can just see here a schematic of them. They start out from the hematopoietic stem cells, which transition to the megakaryoblast, and then the megakaryocyte, which then releases these platelet contents into the bloodstream. And when you look at a platelet, considering that they're only 2 micrometers in size, much smaller than even the red cell, you can see that they are fairly complex cells. They are composed of this canalicular system, they have these energy packets and these microtubules, which allow it to change shape. And then, of course, we know they have the dense and alpha granules, which contain coagulation factors and, more energy packets, ADP, and some cations and other, factors like the serotonin. And we see them frequently in H&E smears. Here you can see them and how small they are compared to the red cells and the granulocytes. But platelets do much more than just acting in hemostasis and thrombosis. They actually play roles in hypertension. They have roles in COVID-19, cancer biology, vascular integrity, immunity, even inflammation, and of course, atherosclerosis. But it's really this, hemostasis is the reason that we transfuse them. So what do these platelets actually do? So if you cut your finger, you can see that you have the site of endothelium here and the site of injury, and the red cells start to extravasate. Of course, the whole blood actually starts to extravasate. And what happens is you upload the von Willebrand factor along with the exposed collagen. And these potentially could be targets in thrombocytopenic patients, for example, that we might exploit. So we see then that the platelets become attracted through the GP1B von Willebrand factor binding site to the von Willebrand factor, and through the glycoprotein 6 collagen binding site to the exposed collagen on the endothelium, and we call this the adhesion stage. Next, the platelets actually change shape and they degranulate, what we call activation. And the alpha granules, again, release all these coagulation factors, and the dense granules or delta granules release things like ADP and thromboxane and so forth. And then after adhesion and activation, the platelets then aggregate, and fibrinogen, binds to the GP2, 2B, 3A site, and this initiates the coagulation cascade. So I kind of liken this to putting the finger in the dam. When you think about thrombocytopenic patients, clearly if you don't have enough platelets, there's not going to be enough to plug up the hole and stop the bleed. So when we think about thrombocytopenia, a normal reference range in average patient or person is 150,000 to 450,000. And we might loosely identify mild thrombocytopenia as 100 to 150,000, moderate 30 to 100,000, and severe less than 30,000. Now, these are not really scientific definitions, just general, and certainly they don't really correlate with transfusion guidelines. Now, the causes of thrombocytopenia. So we break them down into these general categories: hypoproliferative, which is bone marrow underproduction; consumptive destructive, and dilutional, and then something called pseudothrombocytopenia. The hyperproliferative is, certainly one of the, fits, many different types. Certainly there's congenital disorders like congenital amegakaryocytic thrombocytopenia amongst them. And then we have many acquired types. It can be bone marrow infiltration by leukemia, lymphoma, or even solid tumors. They're, very commonly patients with malignancies who are undergoing chemotherapy or radiation therapy, can have bone marrow suppression. There can be nutritional deficiencies that may cause thrombocytopenia as well, particularly folate and B12 deficiency. Iron deficiency anemia, interestingly enough, is associated with a mild thrombocytosis. And then there can be toxicities, infections, certainly alcoholism and viral infections that can suppress platelet production, liver disease because of its association with thrombopoietin, which is a hormone that like erythropoietin, which stimulates red cells, TPO, stimulates platelet production. So if the liver is severely diseased, you can have decreased TPO, and that can lead to underproduction of platelets. And then we have the consumptive destructive mechanisms that can include both non-immune and immune. So non-immune can be disseminated intravascular coagulation, which is a type of a process where, due to trauma or other factors or sepsis, that's triggering the coagulation system to form clots and then subsequently breakdown of the clots and bleeding, and consumption of coagulation factors and the platelets. Splenomegaly, in which the spleen does harbor normally about a third of platelets, but if it's big, it can harbor even 50% or more of the platelets and sequester them. Bleeding, of course, can lead to decreased platelets because of consumption. There can be pregnancy-related complications like the HELLP syndrome. We have thrombotic microangiopathies, atypical HUS, drug-induced thrombocytopenias, and then immune, we know ITP, heparin-induced thrombocytopenia is a type of immune process involving reaction to heparin. Again, pregnancy-related and fetal and neonatal alloimmune thrombocytopenia, which is a complication where mothers make antibody against platelets that cross placenta and damage fetal platelets. And then again, TMAs. TTP happens to be most commonly an autoimmune condition because of the antibodies to the Adams-13 metalloprotease, which prevents cleavage of the von Willebrand large von Willebrand multimers. So you get the buildup of these large von Willebrand multimers and resulting in clumping of the the platelets. And then drug-induced thrombocytopenias and post-transfusion purpura is another type of immune thrombocytopenia that can occur in relation to platelet transfusions. Dilutional can occur when we're giving a lot of fluids or a lot of transfusions, such as a massive transfusion or extensive fluid resuscitation, or even in gestational when during pregnancy the plasma volume increases in relation to the cellular components, and you can get gestational anemia and thrombocytopenia. And then there's the pseudothrombocytopenia, which occurs as a result of an in vitro phenomenon as a result of the EDTA specimen in the anticoagulant. And here you can see a nice picture of that, where you have clumping of the platelets and even satellitism around the white cell. I won't really talk more about this, as this is just really an in vitro phenomenon, but can lead to mismanagement of the patient if it's not picked up, because certainly if you think the patient is thrombocytopenic, and it's not really checked that this is pseudothrombocytopenia, the patient may erroneously get platelet transfusion, for example. In terms of platelet transfusions, we have both prophylactic and therapeutic. Prophylactic when the patient has thrombocytopenia without bleeding, and therapeutic when the patient is bleeding. So when we look at thrombocytopenia versus platelet transfusion, it turns out that a lot of patients have hyperproliferative thrombocytopenia, largely because these are cancer chemotherapy patients. And in the majority of cases, we're transfusing them for prophylactic reasons rather than because they're actually bleeding. So in terms of platelet transfusions, the role of platelet transfusion in reducing mortality from hemorrhage and cancer was first recognized back in 1961. In the U.S., it really has become the leading nation, in terms of platelet transfusions. And again, the majority are prophylactic, given to thrombocytopenic non-bleeding patients. And here we can see a little schematic here, showing that the United States, far leads any other country in terms of its platelet transfusion, and the vast majority of what we're transfusing are apheresis platelets. So we use a lot of platelet transfusion compared to the rest of the world. And here you can see, this is where the original study came from and regarding platelet transfusions. As you can see, this was published in 1962, and they observed bleeding in patients with when the count were less than 1,000, and lower risk when it was between 50 and 100,000. At that time, they picked a threshold of 20,000 as the minimum, but it turned out that many of those patients were on the platelet inhibiting medication aspirin, and so later it became reduced as our baseline is 10,000, as you'll see. So these are the ABB indications that were previously published. And you can see that most of these are really based on, weak recommendations and really just expert opinion. The only one that really had strong recommendation was when the platelets were below 10,000. Other than that, for 20,000 for a central venous catheter, prophylactic transfusion for elective diagnostic lumbar puncture was at 50,000, and bleeding patients again, or those going for major surgery again, 50,000. In the latest iteration of the ABB, and this time combined with this international organization, guidelines or recommendations for platelet transfusion. Again, many of them are based on weak or expert opinion type of evidence. Although now, in addition to the 10,000, they were more certain about the lumbar puncture and actually reduced it to 20,000. So how do we actually manage these patients without platelet transfusion? So one of the big recommendations really is to adhere to the actual guidelines. In my institution, or in my experience, we do tend to transfuse, or I do get a lot of requests to transfuse platelets for lumbar puncture, prior to lumbar puncture, to a much higher level, certainly than 50,000, and certainly 20,000, which is the current guidelines, even up to. And I wondered where this came from, but when I looked at this popular resource online, Up to Date, you can see that there is recommendation to transfuse perhaps up to 80,000. So I wondered who these authors were that were actually writing this, and it turns out one of them is has to do with infectious diseases. The other one was a neurologist, and really nothing to do with hematology or platelet transfusions. So I went to their sources. There were two sources listed. One had to do with these anesthesiologists, so I kind of overlooked them, but these are actually hematologists out of the UK. So what did they actually write? So they actually wrote that, a platelet count of 80,000 is safe count for placing an epidural spinal anesthetic, and 40,000 is safe for lumbar puncture. So I think that Up to Date was kind of misquoted, and kind of leads to a lot of excess transfusions in relation to lumbar puncture, at least in my experience. So getting now to these alternative management options, what's really available to us as physicians to manage these patients. Well, we have TPO agents, the thrombomimetic agents, things like Trombopag and the Romiplostim. Certainly, we want to discontinue medications and substances that may cause thrombocytopenia or interfere with platelet function. And we want to, of course, promote healthy diet and habits. I think we heard of one of the patients yesterday with ITP was talking about eating healthy and having a diet that promotes platelet production. Making a correct diagnosis, certainly if the patient does have an autoimmune condition like ITP, rather than platelet transfusion, giving immunosuppressive therapies like steroids or IVIG or rituximab. And certainly if the patient has, one of these TMAs, thrombotic microangiopathies like TTP, giving plasma exchange or eculizumab for aTPL-HUS. Can DDAVP be helpful? We'll kind of touch on that a little bit. Can antifibrinolytic agents like tranexamic acid or epsilon aminocaproic acid be helpful? And what about synthetic platelets? So TPO mimetics, and we've heard about these a little bit earlier. During this meeting, there was some talk about this, but agents like L-Trembopac and romiplostim and others have been developed since or approved since. So this is a hormone that's produced by the liver akin to erythropoietin for RBCs. It can help increase platelet production, and it's mainly indicated, FDA indicated for treatment of resistant ITP in adults and children. Although it does have some other indications. I think L-Trembopac, I think, for example, has it in HCV-related thrombocytopenia. But it's also been used off-label for treatment of thrombocytopenia secondary to other conditions like MDS, for example, although there is this warning that TPO may precipitate progression to acute leukemia. So certainly it's worth investigating use in other conditions, but you do have to heed this warning. So there has been certainly some studies looking at this. These authors looked at it and said treatment with TPO mimetics resulted in a lower number of MDS patients suffering from bleeding events. So certainly there could be benefit of using TPO, for example, in MDS, despite the warning. Medications and substances that interfere with platelets. So there's many, different medications, particularly antibiotics. Heparin, we know, can have a reduction of platelets either through its transient mechanism or through the more ominous hit mechanism, immune hit mechanism. Chemotherapeutic agents certainly can reduce platelets. Hyperproliferative thrombocytopenia, quinidine is another agent that can reduce platelets. Many medications interfere with platelet functions. Of course, we know aspirin and the P2Y12 inhibitors like clopidogrel, the Plavix, but even other over-the-counter drugs like NSAIDs, for example, can inhibit platelet function. And then dietary and social habits like alcohol, caffeine, and smoking can affect platelet function. In some cases, they may actually make them more stickier, like for example, smoking. And then there are supplements and vitamins that patients may be taking that can also inhibit platelet function. So it's important, of course, to ask platelets, if they're on any of these supplements, more, not just asking about their medications, but if they're taking any of these things like ginkgo biloba or ginseng or garlic or even vitamin B3 or vitamin E can affect platelets. What may improve platelets and increase platelets are folate and vitamin B12, for example. Desmopressin, DDAVP, this is a synthetic analog of a natural pituitary hormone, known as an antidiuretic hormone. It's generally indicated for patients with mild von Willebrand disease, and he can be given also in hemophilia, mild hemophilia. It's given typically as an injection of 0.3 micrograms per kilogram, infused over 10 to 30 minutes. But it can also, besides increasing von Willebrand, it will increase, I should say, von Willebrand factor as well as factor VIII from the endothelial storage sites. However, it does have a tachyphylaxis effect, meaning that once you've released the stored von Willebrand factor, a secondary dose will not be of benefit. So how can this help? Well, we saw in that schematic when I first presented how platelets actually work. you saw that, von Willebrand factor becomes upregulated along the endothelium, and then the platelets were attracted to that, and certainly, kind of enhanced, the function of the platelets, adhesion to the endothelium. So by doing this, you can actually upregulate the function of platelets. But you do have to be cautious when using DDAVP because, patients with severe renal impairment, it can be risky and shouldn't be given. Patients with hyponatremia, because it will cause water retention and lowering the sodium, can be problematic in those with heart failure, and it may also affect the blood pressure. So, using caution with patients with significant cardiovascular disease. For platelets, it's mainly been used off-label to improve conditions associated with mild platelet dysfunction like uremia, but it's not really well studied in thrombocytopenia. However, there is, some evidence in the literature that it can be a benefit. So, for example, here platelets, it was acting on the platelets to generate platelet microparticles and enhance procoagulant activity. But again, it's not really well studied, as these authors point out. The role of DDAVP in perioperative hemostasis for patients with borderline coagulation profiles or thrombocytopenia, may warrant further study, in fact. What about antifibrinolytic agents like the TXA, tranexamic acid, or the aminocaproic acid? So these are agents that block conversion of plasminogen into plasmin and hence stabilize, prevent the breakdown of clots and stabilize them, which can be a benefit in thrombocytopenic patients who are bleeding, for example. So here, though, for patients with thrombocytopenia and hematological malignancies, TXA, probably makes little or no difference to clinically significant bleeding, these authors reported. So they went on to say that those making decisions about administration of prophylactic TXA to people with thrombocytopenia and hematological malignancy should consider that current evidence does not show benefit or harm for TXA or for preventing clinically significant life-threatening bleeding. So again, we really need, more evidence of its benefit for these antifibrinolytics. What about synthetic platelets? There's nothing FDA approved, of course, but there's many different strategies being attempted to come up with something synthetic. Here, they're kind of stripping off the membrane from the platelets to create these these nanoparticles that contain platelet membrane receptors. Other strategies, again, they're kind of using extracting the platelet membranes and then attaching them to these microparticles. Some of them using recombinant strategy, again, to sort of create these artificial platelets. Here again, kind of using recombinant strategy to kind of create these artificial beads, which might be beneficial in thrombocytopenic patients. And then there are others who are attempting to sort of grow platelets using in vitro stem cell technology, either using hematopoietic stem cells or the very immature pluripotent stem cells, or even these embryonic stem cells. And so these are my references, and that's really all I have this morning. Thank you.
Dr. Friedman, that was a wonderful assignment. We appreciate how you address that. You really demonstrate the management of thrombocytopenia for bloodless patients, and we're grateful for all that you do and all of the research that you put in to this particular aspect of surgery. Thank you so much for your presentation. Now we are happy to introduce for World Bloodless Surgery Day. We're going to move right into our keynote address. Dr. Mohammed Biden is a professor and chair of neurological surgery at the University of Chicago Medicine. He is the Stahl Professor of Neuroscience in the Wollman Society of Fellows. Dr. Biden earned a BA at Dartmouth College and his MD at Yale University of Medicine. He continued his training at Johns Hopkins Hospital, completing residency in neurosurgery and fellowship in complex spinal surgery and spinal oncology. Dr. Biden is an expert in minimally invasive and robotic spinal surgery launching one of the nation's first robotic programs in 2015. He is principal investigator of a nationally recognized laboratory focused on data analytics and surgical outcomes, as well as clinical trials of spinal cord injuries. So I'm happy to introduce one of my friends, one of our top shelf surgeons, Dr. Mohammed Biden, as he addresses for us on World Bloodless Surgery Day, Bloodless Surgery, Redefining Surgical Excellence. Dr. Biden.
Thank you very much, Andre, and thank you to Nathaniel and all of the organizers, and happy World Bloodless Surgery Day to everyone. I'm going to share my slides. And hope everyone can see my slides.
Yes.
Okay, good. Great. Well, it's a pleasure to be with everybody. I practice at the University of Chicago, and I'm a faculty member in the Pritzker School of Medicine. So it's a pleasure to be with all of you. I'll tell you a little bit about my practice and how it relates to bloodless surgery and how some of the things that used to require a lot of, or used to necessitate a lot of blood loss can now be done in a very bloodless manner. And these could include surgeries of spinal tumors and brain tumors, by the way, minimally invasive spine surgery and robotics as it comes to these novel surgeries and surgical approaches. I'll show you some different examples of tumors and the things that we do, but also of spine. Back and neck pain are very common diseases. And by many regards, both of those are top 5 diseases nationally. And so those are things that require a lot of focus and energy. This is a case of a 25-year-old with a type of tumor that we call a schwannoma. And you can see here where I'm circling on the left, where that tumor was. And traditionally, a surgery like that might require a large abdominal approach. But there are now minimally invasive approaches like what you can see in the upper right, where we can access the tumor through a tubular manner. It can be done in a microscopic manner, and you are able to deliver a tumor resection without risk of blood loss or a major approach-related risk. And so that's a very big change from where we were a few years ago. Minimally invasive spine surgery is also a really important area and an area of significant change. Like I mentioned to you, back pain is actually the #1 reason for people to see their doctor. 84% of people will have, at some point in their lifetime, back pain significant enough that they seek medical care. Neck pain is #3. Headaches are #2, by the way, other than the common cold. And so other than that, you have, back pain, headaches, neck pain are really very top reasons that people go to see their doctor. And so here's an example of neck pain. This is a 42-year-old female with a left C7 radiculopathy. And you can see on the images, where I'm pointing in the image in the middle, for example, that the problem is at C6 and C7. And that's a foramen that I'm pointing to, which is where the nerve should emerge. And the foramen is too small for the nerve. You can see the equivalent below C7. And how that's very large, and you can see how small that area is. And then you can see on the image on the right where one side, the left side of that image shows really a very compressed area, not allowing that nerve to emerge. So that's why this patient is suffering from neck pain and left arm pain that goes down the arm. And so we do imaging. You can see on the right where I'm pointing is an area of compression where the nerve is compressed, the nerve is pinched. And then you can see here on flexion extension. And then this is the surgical plan. And so in this case, rather than a large open surgery, I did a minimally invasive approach and approached that area, placed an instrument right in that area of compression, and was able to free and decompress the area around the nerve very successfully. This is a 44-year-old male who's got a similar problem where it's neck pain, but in this case, the arm pain is down both arms. And so in this case, a young, healthy person, so we could think about a fusion on one hand, but we could also think about a disc replacement on the other hand, where we preserve motion and where we continue to allow motion to occur. And so this is an example of a disc replacement. You can see on the upper left, that's an example of the disc that's actually removed. That's what disc looks like that I've removed there. And then in the middle, that's an example of me accessing that disc space. To the right, I'm sizing the spacer that I want as a disc replacement. Um, and then you can see on the bottom left and right how that disc replacement device has been placed. And this is surgery that can be done quickly, effectively. The patient can go home the same day. Now, we talked a little bit about neck surgery. I want to transition over to low back surgery. And so this is a 54-year-old male who has pain. Mechanical pain is pain when you stand. The patient says, doctor, when I lay down, I don't have pain, but when I stand, I get the pain. So that's mechanical pain. This is a 54-year-old male with claudication. That's a medical term, and what claudication means is it's difficult to walk. And so patients will say, I have trouble walking, but if I lean over something, I can walk further. I feel better if I lean over something. So, doctor, when I'm in the grocery store and I'm leaning over a grocery cart, I actually feel better and I can walk longer in that situation. So, in this case, you can see in the upper left where the red arrows are, you can see, the white is spinal fluid and the gray are the nerves, but you can see how the discs have pinched off the nerves. And so that's what's causing this problem. And so this is at two levels. And here you have, I can access this with a tubular and microscopic approach. You could also do an endoscope for visualization. And, and I'm able to free these areas and these spaces using this approach. So this is a 51-year-old male who had a prior surgery who now has what's called adjacent segment disease many years later. And so when you have surgery, you can get a problem above the area of surgery. And that's what's happened in his case. And so in his case, we did what's called an endoscopic fusion or a percutaneous fusion, where we do it with very small incisions. It's generally an outpatient procedure where patients can leave the next day. And you can see on the left, before surgery, how there's so much pressure on the nerve, and on the right, after surgery, how that pressure has been relieved. This is a 21-year-old male with what we call a high-grade spondylolisthesis. Now, that's also a medical term. And what that means is that one bone has fallen far in front of the other. So I'll give you an example here. In this image on the right, that's the lumbar number 5, also known as L5. This is sacral number 1, also known as S1. And you can see how L5 is so far in front of S1. Essentially, one part of the spine is moving in front of the other. And that's the problem that we get there. And so in this case, I like to do a case like this in a percutaneous manner. So with small incisions, and you can see I place 4 screws also with small incisions. I'm able to place instruments into the disc space. I'm able to bring back the position of the L5. And then you can see here as I'm doing the surgery and the different techniques that I use. And then finally, you can see how the L5 is now standing much better over the S1 than it used to be before. This is still during surgery. And you can look at the before and after. So on the left is what it looked like before, and on the right is what it looks like after. And you can see how much better it looks in terms of before and after. And this is a surgery that traditionally used to be done in 2 approaches, in 2 surgeries, front and back. And a lot of times it would require 8 screws going from L4 down to pelvis. But now in a minimally invasive way can be done with 4 screws, can be done all from the back, and can be done in a bloodless manner, usually in about 90 to 120 minutes, and the patient can go home the next day. I'll talk to you a little bit about robotics. There's a significant amount of robotics in neurosurgery now, in an area where we never thought robotics could be. And I've been a big believer and a pioneer in this area, and in fact launched, one of the first academic robotic centers, you know, many years ago now. And so robotics enables smaller incisions, reduction in complications, less exposure to radiation, shorter length of stay. This is a case of a 53-year-old female with L5 radiculopathy. And what that means is you have pain. The patient says, doctor, I have pain in my back and it goes down my leg. And in this case, it goes down into the buttock and then into the side of the thigh and then down the thigh into the foot. And that's called L5 radiculopathy. And she has movement, not as severe as what I showed you before, but she also has 2 bones that don't line up. So in this case, I wanted to do a robotic minimally invasive fusion. So first I get a CAT scan. This is my operating room, and this is the robotic machine. And I stand right over here, right next to it. And I utilize the robot for the placement of all of my instrumentation. So I place this pin here, and then I link it to this. And then I place a towel here to do what's called a 3-to-5 scan. And then I do a snapshot registration. I take a passive probe and I take it to my level of instrument. So that's me holding the probe right there. I register. I use fluoroscopy to confirm that my CT and my X-rays are the same. Then I mark my skin incisions. And now in a traditional spine surgery, particularly, in a larger patient, the incision would be very large and would be in the middle and everything would be open, wide open, or it would have to be front and back. But in this case, the incision can be made off to the side with smaller incisions. And then there's many ligaments in the middle of the back that all come together. By going off to the sides, we never touch those ligaments. Those ligaments are preserved, they're protected, and the healing from this surgery occurs by the healing of the muscles off to the sides. So rather than having ligaments completely disrupted and removed, this surgery heals like a muscle sprain, like you've had a muscle, which can be, obviously there's pain associated with all surgeries, but it's much better and much improved relative to what it would be if it was a large open surgery. So I insert my wires. I confirm on fluoroscopy, and that's me. You can see that's the level where the bones don't line up, and that's where my wire is. I start placing my screws. I start at the left L4 pedicle or bone in that area. I place a small drill guide through a cannula. I place my screw into the left L4 pedicle. The pedicle taps over the pilot hole. I verify my integrity, and you can see here on the image, I've drawn where I want the screw to be, and I implement the drawing that I've performed. And then I place all 4 screws in a similar fashion. So now you can see I've placed 4 screws and it's done right there. And this is a very bloodless surgery. This is a surgery where oftentimes we have, 10, 15 cc's at the end. And so it's a very minimal surgery that's well tolerated. And you take a surgery that often used to be associated with multiple blood transfusions for days, and you make it into something that can be done in a bloodless manner. People can go home within 23 hours. I perform my discectomy. I deploy my graft. I place my rods. And I've published initiating a robotic program and what that looks like. And I published the results, which have been very favorable. And you can see here that as time went on, the robot was used more and the operative time was reduced. In addition, we also reduce X-ray time as we do this. And then finally, I'll show you how even multi-levels. So it's not just, one level case that we can do with the robot or that I can do with the robot. This is now done with multiple levels where we can do multi-level surgery in a very successful way and allow people to heal successfully. So there's a big future, obviously, in neurosurgery and spinal surgery, in bloodless medicine, where we allow these surgeries to occur. And these surgeries occur with very minimal blood loss, such that patients don't have to deal with the threat of transfusions for days and weeks on end. Thank you very much.
Thank you so much, Dr. Biden, for that information on and the incredible work that you are doing in advancing minimally invasive surgical procedures for our spine and our neck and neurosurgery. So important. Really, these used to be very huge surgeries. I actually had a friend within the last year who underwent spinal surgery that included the front and the back, and I'm wondering if she wouldn't have been a candidate for a more advanced technique. So thank you very much for this incredible work. Let's open up our question and answer session. And Andrew, if you want to aid me in making sure that we capture all of the questions and the panelists, I'd be greatly appreciative.
Look forward to it.
Yes. One of the questions that I personally had for Dr. Mark Friedman is why is the United States such an use of platelets so much more in their medical management? Is it that we are kind of stuck on the prophylaxis and we have over concern about risk of bleeding?
Yeah, I mean, I think that's part of it. It's not only that we transfuse more platelets, it's also our dose is higher too. Don't forget, because the FDA approved really based on no scientific evidence. This was really just based on when we started first collecting apheresis platelets, it was based on just a pool of 6 random or whole blood platelet concentrates. So we use 3.0 times 10 to the 11th, but when you look at what European nations and Canada dosing it's somewhere in the range of 2 to 2.5 times 10 to the 11th. So they have lower platelets with lower doses, and use less platelets. Why we use more here, it's just become routine practice, and I think I think that has to be looked at.
I was wondering if Dr. Arbach or Dr. Hilwali, hematologists on our panel, have any comments in this area about this or any other thoughts about what we heard today?
Platelet usage is not my expertise. I basically work with surgeons preoperatively to make sure iron sufficiency is present. But I can tell you that in the world of hematology and oncology, there's almost an overreactive hysteria to low platelet counts, and prophylactic platelet transfusions are given, in my opinion, in the overwhelming preponderance of circumstances unnecessarily. And I would be very interested to hear what Mark has to say about that.
Yeah, I mean that's I agree with that. I think that there's a lot of arbitrary transfusions that are given. I mean, we see them all the time in these patients in our outpatient cancer centers, and they're thrombocytopenic, and they're yes, they're on heavy chemotherapy, but then they're just given platelets And then, of course, they develop these complications. Notably, they become refractory to platelet transfusions, and we're scrambling to try to manage this patient who's not responding. And we give platelet transfusion after platelet transfusion, and it's, they're getting minimal benefit from it. In the meantime, we're dealing with platelet shortages, so you get into that kind of conundrum. So I think it's a whole process where we really have to re-educate and reset.
I think
Dr.
Dr.
Hilal,
Hilary had something to say.
yes.
Yes, yes. It's true. Like in our setup as well, most of the consumption is in the line of prophylaxis rather than on demand. So mostly it's related to fear. Most of the platelet consumption in our setup, even in the lowest, resource limited setup, where we are not able even to produce the apheresis through apheresis, we usually use the pooled blood. So mostly it is related to fear. So we are giving more transfusion in terms of the prophylaxis rather than on demand. This is particularly true from our surgical and the gynecologic aspects rather than the medical aspects, because the
Absolutely.
surgical team, the gynecologic team, they fear more of the bleeding and the complication related to that rather than the medical team. Same is true for the pediatric unit as well. So fear of bleeding, particularly intracranial bleeding, is a feared complication when the platelet is lower. So mostly it is related to educating those group of people where the risk of bleeding is said to be lower if the platelet count is like 20 and above. So in our setup, it's mostly related to the surgical and the gynecologic aspects rather than the medical ones.
Could I ask a question to Dr. Biden? It's my opinion that there isn't a surgeon on the planet that can tell the difference between 50,000 and 250,000 in the operating room. Do you agree with that or not?
I do. I think the cutoffs, when you look at the literature of where the cutoffs were established, it was kind of a best guess initially to say, okay, we need this cutoff to be able to operate on platelets. And obviously, liver malfunction becomes a little bit of a different category. And then platelets that are precipitously dropping and you're getting into the 40,000 and the 30,000 and the 10,000, that becomes a different category. But I completely agree that the cutoff doesn't always have to be, traditionally where we've set it at 100,000. And the same with hemoglobin cutoffs. And so all of those, I think, are based on historical literature. And as that gets challenged by my colleagues, now surgeons have a fear, right? And so when you're going into the surgery, because you're thinking when somebody says, okay, 50,000, you're thinking that really means 30,000, 25,000. But as long as that's what that means, I fully agree with you. I think it's very safe to perform many surgeries at the levels that are being discussed, and you can avoid transfusions that way.
Convince the anesthesiologist. Make my life easier.
Can I ask a question as well here? In the era of this robotic surgery, like as you have said, this arbitrary number has come to 50,000 for major surgeries, and for major surgeries, 100,000, minor surgeries, 50,000. So in the era of robotic surgery, what is going to be the cutoff point that we are going to
Right.
use?
Right, because we don't, I mean, the difference is stark. Because, for example, when you're doing like the midline surgeries, there's actually a lot of risks related to what will happen to the central nerves and things like that. But in these surgeries, like the example that I was showing you, we can go in a paramedian way, meaning around the sides. And what that enables is you can avoid that very dangerous territory where all the nerves are. And that also lowers the risk to the patient, right? It also lowers the risk if there were to be a bleeding event, that it wouldn't be right on the nerves, it would be in the muscle and would heal like a bruise. And so to your point, I think that changes the profile of the surgery and of the risk, and in a way that would make you less likely to transfuse.
Yes. I was wondering, I think Dr. Professor Roland Nadoma Igba is also on our panel, and if he would like to speak at all around this subject. You're a surgeon in Nigeria, has robotics in spinal surgery. Is that available in your area?
Thank you for asking me to say something. First, greatly impressed by Dr. Biden's presentation. It seems to me incredible, but we haven't gotten to the level of robotic surgery here, although we are familiar with robotics and what they ought to be able to do for various reasons. There are parts of Nigeria where there is robotic surgery, like Lagos and Abuja. Yeah, but in my part of the country, we have not started doing robotic surgery. I have attended courses on robotic surgery, but we haven't. However, the issue of platelets and how they impact on the surgeon is both historical and emotional. You just go in there and you fear the patient will bleed to death if the platelets are below 100. In fact, you have to do a lot of convincing to persuade a surgeon to go in with a patient with 100. So, but things will change as techniques change, as we become robotics become easily available, and we do minimal access surgery, all right. But robotics will take it a bit higher. So
Yes.
thank you to the president, to Dr. Biden. This is really eye-opening.
Thank you, Dr. Rowland.
Dr. Biden, I'm just thinking and referring to my friend who I don't believe was like even given this option. How much is this prevalent across the United States? Are you kind of pioneering this? Like, is it offered
Yeah.
throughout the United States in many areas?
No, so I started my program 12 years ago, and I was an early believer and pioneer in this area. And the theory at that time was, for neurosurgery, surgery on the brain and spine, you can't do it because the areas are too technical. But the technology began to advance, and the robots became more fine, became more predictable. It's robot assisted, so the surgeon's still there. Many times people ask me, the first time, many times people ask, well, where's it? The surgeon's right there. I'm standing right there, and I'm actually the one that's holding all the instruments and pushing the instruments. I mean, so it's robot assisted. And so that's one of the big differences. And there's a big learning curve. There's some places that buy them and don't use them. Ours gets used, 3, 4 times a week. And so we're one of the higher volume centers in the whole country and a center that has a lot of familiarity with it. But like anything new, there's a learning curve. There's people who are used to how they do it and they don't see a need to change, and that's understandable. And so, all of that results in kind of variability of even if it's available, is it going to be offered to you because is someone comfortable using it? And you can always connect with Andre, and always happy to help anyone, of course.
Yeah, with that in mind, we had one additional question for you, Dr. Biden. Do the majority of your colleagues utilize Cell Saver during spine surgery, especially for your bloodless patients?
Yes, so I think Cell Saver is really important, particularly in an open surgery. The robotic surgeries, the blood loss is so negligent that Cell Saver wouldn't make sense because there wouldn't be anything to save. But yes, certainly in an open surgery, I think Cell Saver is an important addition.
Even like we're preserving the blood, which is all of our goal here today, but the recovery process has to be a much better. Do you know like time to full recovery and functionality, the difference between traditional approaches and now these minimally invasive? And I know that you talked about several procedures, but
Right. No, it goes from months to weeks, really. And so the recovery's better, faster, more long lasting. And rather than 3 months, you're looking at 3 weeks. And so it's a much better and improved recovery.
Yeah, I see that
Someone,
with,
go
go ahead,
ahead.
I'm sorry, sir.
Oh, so if someone, let's say from my area was looking into spine and back surgery, would they have a difficult time getting to the U with insurance if they wanted a more advanced technique?
No, usually it's very straightforward, and you can connect, with me or with Andre, and we can start with, sort of like a virtual interaction, review the records, look at everything. But no, it's very straightforward. We get people from all over the world and all over the US, so it shouldn't be an issue.
Cool. I interrupted you. Andre, did you have something to say?
No, I was going to say I have people that I know, patients that are doing quite well. I mean, 3 or 4 weeks after surgeries performed by Dr. Biden. So I can attest to what he's saying. They're moving and getting around pretty good. Here's one additional question it highlights here. I don't know if this is directly for Dr. Biden, but do any of you use a TAG TEG or similar device to determine platelet function? That's an open question there.
I mean, we have the tight success in our own laboratory. And sometimes we'll see it, they'll run the platelet mapping specifically just to assess platelet function, particularly with patients on like an aspirin or Plavix. Although we do also have the Verify Now instrument, which can alternatively be used, but I think everybody's getting TEG on their brain, so they tend to use TEG now more often.
In our cardiothoracic surgery program, sometimes they will run a TEG before surgery because not only the number is important of how many platelets you have, but what's their functionality. And so it kind of gives them a look going in like, okay, I know my number, but what are the functions? So I do think that is an aspect. I know a question that popped up, I think it was answered through the panelists as well, but Dr. Biden, since we have the time, maybe you could weigh in on it, was I believe it talked about cervical surgery, why is the approach from the front rather than the back often? I
Right.
believe that was
So,
the question. Yeah.
yep. So the approach is from the back when we're doing something called a laminectomy, which is to remove the lamina, which is based in the back, or, excuse me, or a foraminotomy, which is to open that hole that I was showing you where the nerves come out. Now, the approach from the front is called an ACDF, anterior cervical discectomy and fusion, or a disc replacement. And the reason that those approaches are from the front is because that is a very straightforward and streamlined approach with a very rapid exposure. You can go between two planes and you're right there on the spine. Your spine is a lot closer to the front of the neck than you might realize. And that's very different in the lumbar, where it's much further back and in a different space, and you need another surgeon to get you there. In the front of the neck, it's very straightforward. Interestingly enough, that approach was defined by Ralph Cloward, who was the chairman at the University of Chicago long before me, but he was my predecessor. And after a long and very storied career, there are still to this day Cloward instruments that we use. He retired and moved to Hawaii and became the neurosurgeon in Hawaii as well as he was in the mainland US. And so it was, but he's got a really interesting history and story. But it's a very successful approach and one that's been done for a long time, and not one associated with blood loss in a significant way. So.
Andre, if I could ask you a question in your role, because so many people come internationally or around the nation to Chicago, your job becomes very important in coordinating all of these. Can you tell us a little bit about how to connect to you and how you serve them so that you get the medical care that people need all around the globe and the United States?
Yeah, we certainly get a lot of phone calls, definitely for Dr. Biden. and other surgeons. Either they directly call me or they email me and I take in patient information. We have a nice clinical staff inside. We have nice roles. And so I don't have to deal as much with insurance as I had in the past. But certainly we guide our patients. We show them what to do, how to do it, advocate for themselves, because we get a lot of patients just in the U.S. alone. We think about physicians like Dr. Jivanandam. There's only 2 states he has not had a patient from. And so these are reoccurring events. Dr. Biden, too, is getting more and more patients. We discuss working with international patients as well. We're going to work with that a little closer in terms of bringing them in. But always is the insurance is always the big issue and getting it covered. And so, yeah, we work with them. Dr. Biden and his staff also has support with that as well. So if you need anything or any patient is in need of any procedure to see or access Dr. Biden's services, just give us a call. Put the work on us. We're willing to go the extra mile to try to get the patient here and, try to work to overcome those hurdles with insurances.
Being such specialized and pioneers in not only bloodless medicine, but in technology and technique, is there a long wait or do you triage people according to their clinical scenario and how severe?
Exactly. Yeah, we'll triage according to, severity of symptoms, condition, and get people in quickly who need to be and do it based on that. But we can usually fulfill the requests and make people, better.
Incredible work. It was just so impressive to see because that spinal area, that spinal column and all the nerves, such an intricate space to have surgery.
And a major source of pain, of disability. It's actually the #1 driver of disability across the country. So,
yeah, I think you were giving statistics like 84% of people experience back pain. And those are the people who actually seek medical attention. We know a lot of people suffer and just accept it as a part of their daily life. So interesting.
It's just a privilege to have access to a physician like Dr. Biden. Thank you so much for your presentation as well and the detail that you give in showing us how you perform these delicate surgeries.
Thank you. Thank you for having all of us. Yeah, it's a pleasure to be with you today.
Yeah. So shall we move on to, I believe our next, are there any more questions? I want to invite the panelists to speak up at this time or any questions from the audience. We have a little bit of time. Good. All right, well then we are going to invite, let's see here. We have some industry presentations, I believe, don't we, Andre? Is that our next?
There's actually one question in the chat.
How do you aid patients from Nigeria? And is this a question for Roland, Dr. Roland Nadama Igba?
Yes. What's the question again?
Oh, how do you aid patients from Nigeria?
How do we? I haven't gotten the question right,
I mean, I believe they're just asking, how do you help patients in your region? You don't have the advanced technology, and yet you're performing bloodless. How are you carrying that out?
Oh, thank you very much. Dr. Nathaniel Usora and I have done a laparotomy with partial gastrectomies and splenectomy in a patient, a professor, with a hemogram of 6.
Wow.
That's just to say. There's much that can be done, and we are doing as much as possible. Of course, technology is coming in, but not as fast as we would like it. But in spite of that, as you will know, bloodless surgery is not the total absence of loss of blood. So there are, of course, the patient factors, the surgeon factors, all those steps taken to minimize blood loss.
Yeah. And I think too, what I've seen from your
During
team is
operation,
just you,
and of course that. But
yeah.
yes, the principal thing is the
He'll come back up online.
I think just a little bit, yeah. Well, we could certainly come back around if necessary.
I'm always impressed by the Nigerian, their comfort level. I think they practice their skill and they become very comfortable with lower hemoglobins. So
Yes.
I think they don't rely as heavily on the safety net. They just perform their techniques and, you know, really go back to the simplicity of bloodless care and make sure that their techniques are strong and they're very diligent and meticulous and they serve the population so well even without the advanced robotics and technology. So very
Yeah,
impressed by their work
certainly
in
true.
Yes, Sarah,
bloodless.
if I may
Yeah.
add to that and take over from my boss and my teacher who lost connection. Yeah, to add to what he said, bloodless surgery is not all about technology. It's about education. The first thing to recognize is that blood transfusion is of no proven benefit. Then the second thing to recognize is that you can do so much using the bloodless surgery techniques and save patients' lives very effectively, even when the hemoglobin is low. We have a recent published study in the Lancet 2021, which shows that there is no difference between blood products and normal saline for patients in hemorrhagic shock. Now that, again, you have to remember that is a very mild conclusion. That is no difference. But then in medicine, we don't offer a therapy when it doesn't offer benefits. If there's no difference, then why do it? The US study many years ago, comparing again patients who are transfused and those who are not transfused in hemorrhagic shock, showed that those who are not transfused do better. So these are mind-blowing. And if we understand that and understand that the what is typically called the alternatives, which should actually be first line, the bloodless techniques, that they are of proven benefit, there is better outcomes. Then we add that to the fact that rarely we heard from a number of our speakers that it is not the hemoglobin that actually kills the patient or low hemoglobin. No, it is the hemodynamic status. We heard that during the week. So if we take care of the hemodynamic status, I mean, we're okay. I mean, if we solve the primary pathology that brought the patient, we can take our time to raise the hemoglobin. So we have here patients that have had low hemoglobin as low as 1 in our center. And I believe following the science, if we had transfused them, they wouldn't be alive today because we would have done massive blood transfusion and we cannot possibly cope with the adverse outcomes from massive blood transfusion. But with bloodless techniques, you can save people with extremely low hemoglobin. It's not only in Calabar, it's been reported all over the world.
Very good.
Yeah, very nice.
Technique before technology. I like that. Always go back to your foundational principles first. Very good.
Very nice. So this seems to bring our Q&A to a close, Sarah. So we'll just transition right on into our industry presentation. And so on rapid hemoglobin testing as a cornerstone of bloodless medicine and PBM, let's give attention to John Shidiak. I hope I'm so sorry. Briscoe Scientific.
Excuse me, can I go ahead and answer that question?
Sure.
The one on why the doctors in the third world are reluctant to go on the bloodless medicine and surgery philosophy. If I might answer that.
Sure.
Yes?
Yeah.
Please.
Okay. Well, first, as we have heard throughout the conference, when it comes to things like determinants of the preoperative satisfaction before operation, you will see that people are impacted by history, upbringing, society, circumstances, and of course, the economy or the economics of management of any patient. Our doctors are reluctant in many cases because they haven't been exposed to the knowledge. Just like Christ said, my people perish for lack of knowledge. So that's the first thing. The second thing is change is not the easiest thing to accept. It takes time, proof, and practice to accept. One recalls when we started the breastfeeding and total breastfeeding programs. Many grandmothers didn't agree that a baby could last a day without drinking water or adding any other thing to it. So such sociocultural circumstances challenge any new ideas. And so the work that Nathaniel, Dr. Usoro has been doing in promoting bloodless medicine and surgery is going to go a long way to persuading people that this is possible. And in our center, we like the patients mentioned, most of them are referred here. By the early 90s, 1990 or 1991, I had started operating on patients on behalf of Jehovah's Witness because they didn't want blood. But at that time it was exclusive and few numbers. But now that we have come to where we have a World Bloodless Surgery and Medicine Society, that we're having annual conferences and certainly we'll be winning more and more people over. The misfortune of economics makes it even slower because if we had all these technologies readily available, they will further persuade both the doctors and the patients that bloodless medicine and surgery is possible. But I think we're making progress. The mere fact
Certainly
that we
are.
are participating in this conference is evidence that we are making progress. So I rely on the evidence-based medicine that we are doing well.
And
Thank
thank
you.
you so much for your hard work. And we'll move on to the industry presentation with Dr. Shidiak, and he will be speaking on rapid hemoglobin testing as a cornerstone of bloodless medicine and PBM. Thank you, Dr. Shidiak.
Sarah, please let me apologize on behalf of John. He's still having challenges with his laptop.
Okay.
It crashed 2 days ago.
Oh
So I
my.
think he'll be joining us in November for the annual conference, annual meeting of the Bloodless Medicine and Surgery Society.
Okay. So will we move on to Dr. Snyder?
Yes,
So
please.
Let's see.
There's actually a question in the chat. I don't know if you have time for any more questions.
If we're going to skip a presentation, I think we could take another question. Let's see. Where's the chat here?
Yeah, maybe just
There's
one question.
Yeah, is it the question, how does bloodless patient management help reduce unnecessary transfusion in modern healthcare?
Actually,
Go ahead.
actually, in the bloodless world, we believe that all transfusions are unnecessary. Why do we believe so? Simply because of the evidence, as Professor Abidoma said. There is zero evidence of benefit of blood transfusion in any clinical scenario. We have parameters that we check for in surgery, like faster recovery, less wound complications, shorter length of hospital stay, fewer ICU admissions, and so on. So those are parameters that we should check. And none of them is improved by blood transfusion in any of our patients. We don't, at this point, we don't even talk about reducing blood transfusion. We talk about totally avoiding blood transfusion. That's why we have the Bloodless Medicine and Surgery Society. And this year, the theme for World Health Day by the WHO, which was April 7 last month. And I had the privilege of being invited to a radio and TV talk show on the World Health Day. The theme, as part of the theme, was Stand with the Science. So it's asking all of us to stand with the science. And I believe that's part of the reason why the WHO brought out the document in 2021 about the urgent need to implement patient blood management, because the science indicates that not only blood transfusion is associated with adverse outcomes, but it has no efficacy, no proven efficacy after decades of transfusing and after a lot of money has been spent on grants trying to prove the efficacy of blood transfusion since 1988. So have I diverted from the question, Sarah?
No, I don't believe so. I think you handled that well. Is there any other
Right.
panelists that would like to discuss their comments or thoughts on it? Now we will go ahead and introduce Snyder Deve, I hope I said that correctly, and Abigail Avara to handle our Bloodless Medicine and Surgery Basics quiz. And we look forward to that. See what we learned from this conference.
Hello, everybody. I'm Schneider Davy, and we're here to introduce the Bloodless Medicine and Surgery Basic Quiz. So this test is basically designed to test the knowledge of the basic concepts of the bloodless medicine and surgery that you've gained over this past week. So we're gonna see if Dr. Yusuro can see if we can pull up the questions for us. We're going to go over it, and it's going to be a poll. It's going to be a poll design question. So we're going to see where everybody decided to answer.
Yeah, keep your fingers crossed because I'm not as good as fixing.
Okay. Okay. I see the poll ahead of me. I just wanted to see if I can get a thumbs up from somebody else if they see the poll as well. Okay, great. All right, so we see the first question. The question is, complications of blood include A, non-nosocomial infections, B, thrombosis, C, inflammation, D, cancer recurrence, and E, all of the above. We're going to give about 5 seconds each for each of the questions.
You may go on, Schneider.
Okay. So we're going to move on to the next question. It's question number 2. It says, choose the most most appropriate correct answer. So A, blood transfusion results in increased morbidity and mortality in virtually all patients. B, leukoreduction removes the immunological problems of RBC transfusions. C, platelet transfusions are generally safe and effective. D, plasma transfusions are safer and more effective than alternatives. Or E, type 1 immune infection is not antagonist by allogeneic blood transfusion. Okay, we're going to move on to the third question. Hopefully everybody has their answers in. It's regarding anemia. Which statement is not true? A, iron deficiency anemia is the commonest form of anemia worldwide. B, immune deficiency can lead to immune dysfunction. C, blood transfusion remains the gold standard in treatment of anemia. D, iron deficiency without anemia is a threat to surgical outcomes. E, anemia and iron deficiency are the most commonest and modifiable risk factors in surgery. So that was the
It
number
looks
3.
like some people in the audience say they cannot see the poll. I wonder whether it vanished. So it's not showing on my
It
screen
didn't vanish.
anymore.
It didn't move forward. It didn't change to the next question.
Oh, it didn't. I wonder why. It's supposed to show.
It's not showing.
So I see the responses stopped at 2,
Yes.
and I wonder what would happen if I stop the poll. Maybe I should relaunch it.
That'd be better.
That's possible. That most likely that you have to.
Let me try relaunching.
Oh, I think someone says to just scroll. Someone said they can see it, but just scroll.
Yeah, you just scroll down, please, on your own screen.
It's not even showing in mine. It's very launched.
The concern is that if it's relaunched, I don't know what will
Nathaniel,
happen. Yes, please.
Nathaniel, if they can go into down by the chat, there is something
Okay.
called more, and
Okay.
press on pool and quizzes, pools and quizzes, and that's how you can see it and move it.
That's how I can do it.
Yeah, I can do. I lost it, but then I get it again by this way. So if everyone can do that.
Okay.
I see
So,
people answering number 3 right now. People are answering number 3.
oh, okay, good. Good. So other people have discovered how to move on
Yes.
by scrolling. So Abigail, you heard that if you go to more and then you go to polls and quizzes, you can get it back.
Okay.
All right. So back to you, Schneider.
Okay. Since we see that there's some response with answer number 3, we're going to move on with answer number 4. With question number 4. So it asks, regarding raising the hematocrit, anemia is more dangerous than transfusion. Intravenous iron without erythropoietin can effectively raise the hemoglobin. C, erythropoietin without IV iron will effectively raise the hemoglobin. D, erythropoietin contraindicated in oncology. Or E, intravenous iron and erythropoietin are only useful in elective surgeries. We see some responses coming in for 4.
How do you get the quiz up?
You just scroll on your screen.
If you go to the left to the right side of your screen, the scroll bar will appear. Now we're going to move on to number 5. Which of the following is not true of preoperative autologous blood donation? A, clerical error can occur. B, storage lesions will occur just like a donor blood. C, bacterial contamination can occur. D, anemia does not occur and there is no wastage. And E, transfusion-associated circulatory overload can occur. So moving on to question number 6, it asks, regarding sickle cell disease, CSD, we're going to have a single choice. It's going to start with A. Is it not possible and not healthy to avoid blood transfusions completely? Intravenous iron is not contraindicated in SCD patients. Major surgeries in SCD patients will require blood transfusion. And D, blood transfusion does not introduce the etiological factors in sickle cell crisis. And E, hydroxyurea can decrease pain, acute chest pain syndrome, and hospitalization, protect other organs, and increase hemoglobin and lifespan. And number 7, regarding hematological malignancies, which statement is untrue? We're going to start with A, bloodless care is both possible and desirable for improved outcomes. B, intravenous iron and erythropoietin are effective in raising the hematocrit. Targeted therapies cannot be used without erythropoietin. And D, stem cell transplant is possible and has better outcomes without blood transfusion. And finally, E, hemorrhage can be safely prevented or managed with TXA, EACA, and DDAVP. We're going to move on to number 8. It says bloodless medicine and surgery. We're going to choose one of these choices. It starts with A, is currently the standard care rather than an alternative. B, is the provision of quality Medicare without the use of donor blood with the aims of improving clinical outcomes and protecting patients' rights. C, 3 pillars of bloodless surgery are adopted by the WHO as the 3 pillars of PBM. D, Dr. Denton Cooley is regarded as the father of bloodless surgery because of his pioneering work in bloodless open heart surgery. Or E, all of the above. Number 9, regarding blood health, we're going to choose one of these answers. Starts with A, the blood principle are not acceptable in, hopefully I'm saying this correctly, thalassemia. Is the optimal function of individual elements of blood and their associated interactions with all other organs and organ systems. C, blood transfusion is a less complicated organ transplant. D, blood is an organ with limited regenerative capabilities. E, platelet transfusion is generally based on high quality evidence. Scrolling down to the last question. It asks, regarding the role of hematologists in bloodless medicine surgery, we're going to choose one of these answers. A, optimizing the hematocrit is primarily done by anesthesiologists, pillar number 1. B, hematologists have no role in minimizing blood loss, pillar number 2. C, supporting patients' blood tolerance of anemia is done usually with appropriate blood products, pillar number 3. Hematologists are critical in bloodless medicine programs and can even play leadership roles. And finally, E, optimizing tissue oxygenation involves administering RBC transfusions. Pillar number 4. So that's the end of the question. Daniel, would you like to click end the poll?
Yes, but I think we can allow a few seconds or more for those who are still on the poll because answers are still coming in.
Okay.
Sarah, I know you're equal to the task. Could you play some music for a minute? That's fixing.
Okay.
There's someone whose hand has been up throughout, Mohammed Bilal. I wonder whether he wanted to make a comment or something. Maybe instead of, okay, he has removed his hand. So otherwise, we would have empowered him to say something. Okay, I think I can end the poll now. Run out of. So what is the vote? Should I end the poll of our moderators?
I see.
I think everyone has had sufficient
Yeah.
time to answer.
Yeah.
All right, good. So I'll share the results, and I hope the answers will come up as well. Right, okay. So starting from question number 1. Complications of blood transfusion include, yes, all of the above. We heard that from the first talk from Dr. Blomberg. And number 2, choose the most appropriate correct answer. Blood transfusion results in increased morbidity and mortality in virtually all patients, certainly. Leukoreduction removes the immunological problems of RBC transfusion. No, they don't. To start with, the term is leukoreduction, so it doesn't completely remove all of the white cells which are blamed for a lot of the immunological problems. And Dr. Blomberg did suggest that it would help. Leukoreduction is done in Europe, in the UK, but in the US, studies have shown that it doesn't help. The outcomes are still bad with leukoreduced blood. Platelet transfusion is generally safe and effective. No, Dr. Blomberg told us about the many problems, including sepsis, bacterial contamination, even multiple organ failure. And he suggested that it could be improved by making sure that we don't do ABO mismatch transfusions of platelets, which is the norm, but certainly not safe. And if efficacy, again, it has been found that patients transfused with platelets, when studied, actually bleed more. And Dr. Blomberg also tried to offer some solutions to that, but generally at present, it's not safe and effective, and certainly not more effective. Plasma transfusions are not more effective than alternatives. We heard that there's one of the slides. Let me check which of the slides it was that specifically said it. I can find it right now. Anyway, we'll all have the slides at the end, so we'll have a good look at all of them. And we've had a talk on thrombocytopenia today. Type 1 immune function is not antagonized by allogenic blood transfusion. It is. Dr. Blomberg had a slide that showed us how blood transfusion antagonizes type 1 immune functions that have to do with bacteria, with viruses, and with cancer. So all those become more prevalent, or the incidence is more with transfused patients because type 1 immunity is compromised, according to the studies. Regarding anemia, which statement is not true? Just checking to see if I still have time. Yeah, iron deficiency anemia is the commonest form of anemia worldwide. That's correct. It was there in Dr. Villaseca's slide on Tuesday. Iron deficiency can lead to immune dysfunction. It was also there in her slide. Blood transfusion remains the gold standard in treatment of anemia. Not true. Her slide showed us that if raising the hemoglobin, standard is iron therapy. And for surgical patients, she also had on her slide, the gold standard is intravenous iron. I'm sorry, I think there must have been a mix-up here, because the question is which statement is okay, so it's that is not true. C is not true. A and B are true. D, iron deficiency without anemia is a threat to surgical outcomes. It was in Dr. Villaseca's slide that sometimes there might be no anemia, but there's iron deficiency, and it increases the incidence of surgical complications, including cardiac and immune complications. Anemia and iron deficiency are the commonest modifiable risk factors in surgery. It was also on Dr. Villaseca's slides that these are the commonest. Annalisa says the internet connection here is unstable and we missed the quiz. Sorry, but you're getting the answers. So you haven't missed everything. Yes. So, okay, so number 4, regarding raising the hematocrit, anemia is more dangerous than transfusion. Not true. Dr. Jamila Satha showed us slides that showed clearly that transfusion increases adverse outcomes, even in anemic patients. And in non-anemic patients, transfusion increases the adverse outcomes and death by 2-fold for non-anemic. But for anemic patients, transfusion worsens the outcome 3-fold in the studies that she showed us. Intravenous iron without erythropoietin can effectively raise the hemoglobin. Yes, she gave us 3 situations in which erythropoietin might be indicated. One is where rapid increase in hemoglobin is required. And the second one was where there's anemia due to chronic disease or chronic inflammation. And the third one was anemia due to chemotherapy. So, but outside those situations, you can, IV iron on its own is a potent stimulant for erythropoiesis. I think Dr. Auerbach is still here. He's a world authority on IV iron. I believe he can contribute to that. Erythropoietin without IV iron will effectively raise the hemoglobin, not usually. It can rather cause functional iron deficiency. So it's advised that whenever we are going to use erythropoietin, we should give the patient intravenous iron before we start the erythropoietin. Erythropoietin is contraindicated in oncology? No, not at all.
Or at least ensure that iron sufficiency is present.
Right. Exactly. So erythropoietin is contraindicated in oncology? No. Dr. Satha, that's Jamila, showed us a slide that erythropoietin is not an oncogene, and the receptors for erythropoietin on the red cells completely different. There's negligible action on cancer cells, according to many studies. IV iron and erythropoietin are only useful in elective surgeries. No, again, she showed us that you can rapidly increase the hemoglobin with IV iron and erythropoietin. There was a graph she showed IV iron and erythropoietin and blood transfusion superimposed. And there was hardly any difference. But as time went on, she showed us in the graph that the effect of blood transfusion waned. Whereas that of IV iron and EPO kept increasing the hematocrit. And we found that in practical experience. Sometimes we transfuse patients and the hemoglobin actually drops instead of rising. Yeah, so it is a myth. It's a myth that it takes a long time to raise the hemoglobin with IV iron and EPO. No, it's those things, as soon as they get into the body starts working and producing erythroid cells. Number 5, which of the following is not true of pre-op autologous blood donations? Clerical errors can occur, definitely. Storage lesions will occur just like in donor blood. Yep, because once you store the blood, it starts to degrade, just like in donor blood. Bacterial contamination can occur, yes. Anemia does not occur, and there is no wastage. Certainly anemia can occur. That's why in those days when it used to be practiced, erythropoietin and IV iron would be given alongside because you can induce in a patient that wasn't anemic by carrying out preoperative autologous donation, you can actually induce catastrophic anemia. There is no wastage. No wastage is one of the problems because let's say we draw the blood, it's over a period of maybe 3 weeks, draw 1 unit this week, draw another one next week, draw another one the 3rd week. And when it's time for the surgery, we end up using bloodless surgery techniques and the patient loses hardly anything. So now we say, okay, there's no need for the blood that we had drawn already. And that's wastage because the patient was not donating the blood for others. And that blood cannot be used for anybody else. So it's wasted. Transfusion-associated circulatory overload can occur. Certainly, it can occur. Because again, maybe we did the surgery and we conserved the blood so well, like our patient in obstetrics, gynae, that was operated on this week, bloodless CS, went in with PCV of 30%, came out with PCV of 29%. And let's say we had drawn her blood and kept preoperative donation. And we are pitting the blood. We want to put the blood back into the patient so it won't be wasted. That can lead to transfusion-associated circulatory overload. So the correct answer is D. That is to say, that is the only answer that is not correct. Anemia does occur, and there can be wastage. So I don't think any bloodless programs practice preoperative autologous donation anymore because it's not scientific. Regarding sickle cell disease, it is not possible and not healthy to avoid blood transfusion completely. Of course, it's possible, it's healthy. We saw some ACD patients who have not had a transfusion for decades, and they're perfectly all right. Major surge, intravenous iron is contraindicated in sickle cell disease patients, no. Dr. Essien told us how she's been using IV iron, and we have literature that shows that sickle cell disease patients can and should have IV ions, especially when their IV ion stores are low. The iron they have may be sequestrated, and moreover, those who argue against IV ion often transfuse blood. That's their alternative. And each unit of blood has 200 milligrams of iron anyway, which is probably the only thing the body uses. So why not just give the iron as iron instead of as blood transfusion? Major surgeries in ACD patients will require blood transfusion, no. We've had also on the program patients who have had major surgery, no transfusion, and they were perfectly okay. Blood transfusion does not induce the etiological factors for sickle cell crisis. It does. So it can induce hypothermia, acidosis. It can increase blood viscosity. Blood transfusion on its own causes thrombosis and stroke. So in sickle cell diseases, it will obviously increase the incidence. Hydroxyureas can decrease pain, acute chest syndrome, and hospitalization, protect other organs, and increase hemoglobin and lifespan. This is straight from Dr. Su's slides, and he is an authority on these matters. So correct answer is E. 7, regarding hematological malignancies, which statement is untrue? Bloodless care is both possible and desirable for improved outcomes, definitely. We heard that from the Professor Lalin. I'm sorry, I'm not able to. Gunaratne, I think that's, if I pronounce it right. The professor from Sri Lanka. Dravino's iron and erythropoietin are effective in raising the hematocrit, correct? Targeted therapies cannot be used with erythropoietin, not true. They can. Stem cell transplant is possible and has better outcomes without blood transfusion. That is what we heard from Kerry and Jen from Pennsylvania Hospital. Hemorrhage can be safely prevented or managed with tranexamic acid, epsilon aminocapric acid, and desmopressin. Yes, so the correct answer is C. Targeted therapies cannot be used. It's not true, because we're looking for the answer that is not true. 8, bloodless medicine and surgery is correctly the standard of care rather than an alternative. We heard that from multiple speakers. It is the provision of quality medical care without the use of donor blood, with the aims of improving clinical outcomes and protecting patients' rights. Wow, that's correct. Okay. 3 pillars of bloodless surgery were adopted by WHO as the 3 pillars of PBM. We heard that from Sherry's talk about Dr. Denton Cooley. Dr. Denton Cooley is regarded as the father of bloodless surgery because of his pioneering work in bloodless open heart surgery. That's correct. And we heard from Sherry that Dr. Cooley himself regarded his bloodless surgery as the main, his main contribution to the world of surgery, whereas we mostly think about him in terms of cardiac surgeries and innovations. So the correct answer is E, all of the above. Regarding blood health, the principles are not applicable in thalassemia. They are applicable. Dr. Yap, Yap specifically put in blood health in her slide. It's the optimal function of individual elements of blood and the associated interaction with all other organs and organ systems. That's what Sherry said. Blood transfusion is a less complicated organ transplant. No, it is an organ transplant far more complicated. All the antigens are there and more, and it goes everywhere, unlike solid organ transplant that stays in one place. And also, of course, we don't give immunosuppressants after blood transfusion, but I think we're supposed to. Blood as an organ has limited regenerative capabilities, quite the opposite. It was also there in Sherry's slide that blood has amazing regenerative capabilities when given the chance. Platelet transfusion is generally based on high quality evidence. That's not correct. We saw it today in Dr. Freeman's slide. A lot of it is low quality evidence. Regarding the role of hematologists in bloodless medicine and surgery, optimizing the hematocrit is primarily done by anesthesiologists. No, it's hematologists. And we heard that from Dr. Essien. Hematologists have no role in minimizing blood loss. Again, she showed us that, yes, they have a role, right from diagnosing and treating bleeding disorders. And if much bleeding does occur, even in the OR, they can help to figure out why and treat it. And thromboelastography and so on, they can help with that. Supporting patients' tolerance of anemia is done usually with appropriate blood products. No. The WHO is encouraging us to avoid blood products and rather support patients' tolerance of anemia with IV iron, EPO, and other supportive measures. Hematologists are critical to bloodless medicine programs and can even play leadership roles. That's correct. We can't talk of having a bloodless program without hematologists. Optimizing and pathologists, of course. Optimizing tissue oxygenation involves administering RBC transfusion. The opposite. There have been studies that show that RBC transfusion causes hypoxia because of storage lesions, both mechanical and biomechanical. And I think correct answer is D. Hematologists are critical to bloodless medicine programs and can even play leadership roles. So that's the end of the quiz and the answers. I don't know if anybody has any contribution they want to make. Can I stop sharing?
Nathaniel,
Okay.
just one comment.
Okay.
On the autologous donation, we still do it for Jehovah's Witness patients in some cases where cell saver is not an option, and just because we want to avoid transfusion. And as you probably just heard recently, the society approved now an autologous donation to be used if needed. So we're still doing this.
Okay, so we don't do it because the published literature shows that there can be storage lesions. And of course, storage lesions would lead to hypoxia. And I mentioned all the other things, clerical errors and so on.
Yeah, no, I
So
understand. I totally understand, but sometimes it's the only option.
Well, we can if we're giving blood that has storage lesions, we might as well use colloids because all we are doing is administering a colloid to maintain hemodynamic status. It's not helping with oxygen delivery because the red cells are abnormal. 2,3 DPG is gone.
Of course.
Yeah.
We published this. We published that study.
And it can cause a dilutional coagulopathy because the platelets are gone after 24 hours, and so on and so forth. So if one is going to just use it as a colloid, then one can use, in my own setting, we do have colloids easily available and very good. But
we're running out of time.
Contribution.
We're running out of time, so
okay. I don't know what I did here. I wanted to stop. Can I stop the share, please?
You can stop the share. It's not showing. It's not showing here. Thank you, Dr. Nad. Co-moderator Schneider, you've done a good job. All this quiz is just a summary of all the week's presentation. And for those who likely did not feature in the past days, at least they've got a summary of the lectures during the week, and they've learned a lot. So really appreciate you and all the presenters, you've done too well. So at this juncture, we have closed the quiz. Any question you can ask the moderators, type at the Q&A section. So I want to hand over to the co-chair of this conference, Sarah Pearson. Kindly take over.
So as we come to the close, first of all, I'd like to apologize for the technical difficulty. I wasn't able to play the video initially, but I would definitely play it at the end. So as we come to the close of this remarkable session, I would like to extend our sincere gratitude to everyone who made today possible. A special thank you to our distinguished speakers, moderators, and panelists for sharing your expertise, insights, and dedication to advancing bloodless medicine and patient-centered care. Your contributions continue to inspire meaningful change across healthcare systems worldwide. We also warmly thank all attendees from across the globe for your active participation, thoughtful engagement, and commitment to this important field. Your presence truly made this program impactful. Our heartfelt appreciation goes to the organizing committee, volunteers, technical crew whose hard work behind the scenes ensured the smooth coordination of today's event. Your dedication and teamwork are deeply appreciated. We're also excited to invite everyone to, with the theme for our next meeting, with a theme, the urgent need to implement bloodless medicine. At this time, Schneider, can you kindly share your the conference poster on the screen? So we encourage all participants to submit abstracts for BMSS 2026 beginning June 1st via email at info@bmssociety.org. Again, it's info@bmssociety.org. We look forward to receiving your innovative research, experiences, and contributions to the advancement of bloodless medicine and surgery. So before we conclude, we would like to invite all the panelists to kindly turn on your cameras for a group photo while we take screenshots for about a minute. So please smile. Okay, all done. So finally, it is now my great honor to hand over to the chairman of the 2026 conference organizing committee, Dr. Nathan Osuro. Dr. Nathan.
Thank you so much, Sarah. Let me add to your thanks again to all our speakers, our moderators, panelists, and all attendees. We really appreciate what you've done, sacrificing your time and energy without pay to make sure that the scientific message goes out to the world and you save lives all over the world. We deeply appreciate that. There are some people who have also been working behind the scenes, like our webmaster, Folusho, who has been updating our website and spending his own money, to renew the subscriptions for the website. We greatly, greatly appreciate his hard work. And the Secretariat of BMSS that has been producing all our posters and programs, headed by Udrak Sunday, supported by Blessing Ekwe. We greatly appreciate. Please, just a quick reminder to everybody that the month of May has not ended. So the Bloodless Medicine and Surgery Awareness Month continues until the 31st of May. We should all continue to raise awareness of the superior outcomes of the practice of bloodless medicine and surgery by giving talks in our centers. We had one in my own center in Haematology department. It was greatly appreciated. We should give clinical case presentations in the department, journal club presentations, social media posts, and any other valid means that we may think of to share the message. And so I thank everyone, and of course, not forgetting my co-chair, Sarah Fixon, who has been phenomenal. I'm not sure how we could have run this conference without her. That's a multi-talented nurse who is also highly tech capable. I thank you so much. So at this point, I'm declaring today's session closed and the Bloodless Medicine and Surgery Week 2026 concluded. Look forward to seeing you in November for the annual meeting of the Bloodless Medicine and Surgery Society. Thank you, everyone, for being here. And bye-bye.
Thank you, Dr. Osuro. Thank you so much.
Thank you, Andre.
Bye to everyone. And
Nice
see
job,
you again.
Sarah.
See you in November.
Thank you.
Both